I just wanted to make a video that focuses on a bunch of miscellaneous tips and information that I think will help all of you, okay? Let's get started. Number one, the optimal pressure for you may not be the pressure that best resolves apneas and hypopneas. Sometimes it's a little bit higher or just a different pressure altogether. Number two, something I wish I knew a long time ago, nasal breathing is everything. You have to be able to breathe through your nose. It's called nasal CPAP, not CPAP. And the literature is very clear that when you resolve substantial nasal resistance, PAP effectiveness and compliance skyrockets. A little at-home test that you can do to get an idea for where your level of nasal resistance is you can get oxymetazoline. Brand name for that is Dristan or Afrin. It's probably some other brands as well. You spray that in your nose for a few nights. You're not supposed to use it long-term because rebound effects, but it'll help your turbinates essentially recede. And you'll get an idea if the soft tissues in your nose are posing a problem for your breathing. The arousal threshold is a very important concept in sleep disordered breathing. And it's often the patients with very low arousal thresholds who are going to be dismissed, marginalized, gaslit, and so on and so forth. Because what happens is some patients are super sensitive, and when there's resistance in the airway, just a little bit of resistance is enough to essentially wake them up. And they never have the apnea or the hypopnea. They never have these more commonly understood events that the vast majority of sleep doctors or general physicians are searching for. But instead, they're having physiological responses and their airways are opening. And so they're never arriving at the criteria for those events. And so the healthcare professionals, those who are not in the know, so to say, they think nothing's wrong, but that couldn't be farther from the truth. Just imagine this for a moment. Imagine you have a large weight on your chest. You put a bunch of weight on your chest, lay down and breathe. You can still breathe. You can still get even full breaths. In fact, you could make your Oscar waveforms look normal. You just have to put in a lot more effort, right? Well, apply that idea to sleeping. If you're pulling for air, yeah, you don't have weights on your chest, but you have obstruction in your throat. And your response is to essentially pull harder. And if you pull too hard, your body's gonna wake up. Naturally so. I mean, it's kind of a good thing. There's a redeeming quality to it, right? You never actually desat and have all these consequences of hypoxia. But the issue is that you're being woken up all night and your sleep is being fragmented. And imagine you have a high threshold of arousal, right? And here's the effort to breathe. If you have a high one, even though you're pulling hard to breathe, let's say, you're not actually hitting that threshold of arousal and you're never actually being woken up. But what if your threshold of arousal is way down here, right? Well, now you're going way past that threshold and you're gonna wake up essentially every time that effort reaches that threshold and fragment your sleep. There's this idea in sleep medicine, this consensus that sleeping pills are just forbidden in all cases. That is just simply not true. Yes, you do have to be very careful because imagine you have a very high threshold of arousal. I mean, you want to wake up if you're not getting oxygen and you're struggling to breathe, right? And so to raise that doesn't really make a whole lot of sense. But what if you're like super sensitive and you can give just the right amount of dose to sort of just raise that threshold of arousal and prevent yourself from being woken up? Now, I'm not sitting here encouraging people to go get sleeping pills or anything. Personally, I'll do anything not to take them. The point above all that I'm just trying to make is that this is a conversation that you could have with your doctor. And perhaps you are a candidate for sleeping pills, and perhaps those sleeping pills could bring you into a better quality of life. Another thing I've learned is that, random number, but 99% of healthcare professionals say one thing, and then all the people at the Centers of Excellence in Sleep Medicine, although there's still disagreement there, say another thing. And there's just such a lag, it seems, to get this field up to speed. And as someone who works with patients one-on-one from across the world, whether that's Croatia or India or Ireland or Mexico or Brazil or Germany, I just hear the same thing over and over and over. Doctors telling the patients things that directly contradict the literature that, say, comes out of Stanford. I'll say this too, all the people who I do deal with are typically patients who have like, let's say, aversion to authority. Everyone's being told by these doctors that, no, there's nothing wrong with you, for example, or no, we've already cured you because your AHI is under 5, which is not true, obviously. You know, the people who are disagreeable and who are untrustworthy, they go, no, I just don't believe that. And everyone else sort of just, or many people, many patients are just accepting what the white coat and stethoscope said to them, which is the way it should be. You should be able to go to your doctor and hear something from them, and be able to trust that information. Another thing I would say I've learned is focus on how you feel. Do not try to obtain some objective ideal through your Oscar data. I want you to think of something. At some point in time, sleep disordered breathing became problematic and intolerable for you, right? But before that, you probably had it. What, at 50%, let's say? Let's be conservative and say you had it at 50% of the severity that you have it now. Well, all that sleep was completely disordered, but you were okay with it, right? We're not trying to arrive at some ideal. We're trying to arrive at, not having hypoxia and feeling good when you get up. And if you can achieve that, I think you've won this battle. I see far too many patients making it a way of life to constantly think about sleep disordered breathing. I'm trying to do that so that you guys don't have to. Dr. Rama, in an interview with Jaw Hacks, brought up a really good point that I think is often overlooked. It can become a disorder thinking about your sleep. I think most of you, when you're lying alone in the dark with your conscience, would admit that there were some days that perhaps you could have had a much better day had you not dwelled upon sleep disordered breathing, or had you not sort of came to a conclusion about the quality of your day in the first 5 minutes of you waking up because maybe you felt like shit. What I'm trying to say is that don't let this completely rule your life. Yes, I know there's gonna be some of you who are gonna sit there and write, I don't have a life because this is so shit and this sucks and I can't do anything and I'm on disability or whatever. And I'm not saying you're wrong, but I'm speaking to a percentage of you who I know could benefit from pulling back a little bit on the intensity with which you think about sleep disorder breathing and how much it is truly affecting your life. I hope to present soon some data on the cognitive differences between those who are treated on CPAP and those who aren't. I think you would be quite surprised at some of the results. You're more capable than you think you are. It's just that you have this cloud of emotions, thoughts, and fears constantly sort of accompanying you throughout your day, and it doesn't feel normal, and you don't feel like, therefore, you can act normal or exert yourself as you normally would. But I encourage you to try to override that thinking. I'm not trying to belittle or take away from the suffering that I know so many of you are intolerably dealing with, but I know that there are some of you where this message is going to register and prove helpful. And that's the reason I'm saying it. Sleep disordered breathing is quite possibly one of the greatest blunders and missteps of humanity of all time. I speculate that there's at least 2 billion people who have sleep disordered breathing. I don't have a randomized control trial for that, but I did do a video on how many people have sleep disordered breathing, or an AHI above 5 was one of the things that was looked at. And they came to a conclusion of about 1 billion. So imagine if you included everyone being low in AHI 5. I had an AHI less than 5. So all RDIs that are over 5, let's say, and even people who are symptomatic who have RDIs less than 5, which is a huge percentage of people, I believe. But I don't have data to support that, but I do run into it quite a bit, being in this space all day, every day. Another thing, think of therapy as a combination of efforts. Don't expect CPAP to bat 1,000. As someone, again, who works with patients one-on-one, I get the most motivated and resourced patients you could possibly imagine. And in the cases where I see that patients have come the farthest with respect to resolving their sleep disorder breathing through treatment and therapy, most of them are doing more than one thing. They're either on PAP, bilevel, or ASV. They have like nasal dilators or strips or soft cervical collars or chin straps, or they get a surgery or inclined sleeping. Typically it's more than one thing. And I just encourage everyone to consider that. Another thing which I think works very well, but again, I'm not a big fan of mandibular advancement devices, but I think if they're on, lowly titrated settings, they can be quite helpful, and especially in the shorter to medium term, and if you're younger and so on. But yes, that'll be a discussion for another video, but they can be very problematic and detrimental. But a mandibular advancement device in tandem with a PAP, like CPAP or bilevel, helps a lot. At the end of the day, we're just trying to get rid of your obstruction. You can intubate yourself, and then technically you would have no obstruction, right? Or you could apply 1,000 centimeters of water pressure and your airway would be open, right? But obviously that has to be balanced with comfort and side effects. And we can't just put people on 1,000 centimeters of pressure, right? But the idea I'm trying to get at, anything that's going to alleviate some obstruction, resistance, or flow limitation, by the way, those terms are basically all interchangeable, is going to help us get to the end point that we're aiming at, right? Another thing I want you to know, PAP therapy is not going to work for everyone. There could be a variety of reasons for this, whether this is too restrictive of skeletal structure, too high of loop gain, too sensitive of a patient. These patients do exist. And I asked this question to Dr. Robert Thomas in the recent interview, which I encourage everyone to go watch, especially if you're interested in the concept of loop gain. I said, look, are there people who just, you can't hear them? And unfortunately, for now, though perhaps this isn't the long-term answer, his answer was yes, some people do have sleep issues beyond what we can treat for. But the literature also shows that, even with respect to, if we isolate obstruction, PAP isn't necessarily going to open everyone's airway. Some people have too restrictive of an airway, or the tongue is too heavy, it's too much meat, the bones are too close, and you just can't open it up with some pressure. Just because AHI and even RDI is low, that is below 5, does not mean that there is not a problem. What is important is to know if there's a physiological response to the obstruction. That's pretty common sense. The obstruction should only be an issue if you're having a physiological response. I could close my mouth right now. I just obstructed my airway, but is there a physiological response to that? Did I become hypoxic? Did my heart rate spike? Did my sympathetic nervous system activate? It's my personal opinion that the greatest disservice that is occurring in this space is that those patients who are very sensitive and have very low thresholds of arousal and who do have coinciding physiological responses to small amounts of obstruction and resistance are dismissed, marginalized, gaslit, and so on and so forth. I think the number of patients that is happening to is staggering. Sleep disordered breathing can be very complex. Sometimes it's super simple and vanilla, and it's just some obstruction in the pharyngeal airway and you just need to apply a low CPAP pressure and we're done. But many other patients have a more complex case, and there are different mechanisms that I've presented partially and that I'll continue to present on my channel that can play a role in creating sleep disordered breathing. And so what I hope everyone does, and I encourage everyone to do, is to understand their specific individual sleep disorder breathing profile. Everyone is different. Maybe you have high loop gain. Maybe you have high obstruction. I don't know. But you can figure these things out now. Last thing I want you guys to know, collect your data. You may not care right now. You may think it's not important right now, but just stick an SD card in your machine if you're using a PAP, or just start to understand what's going on, the patterns in your life with your sleep, and you'll start to draw conclusions. And you can use those as actionable conclusions to better your sleep and better your quality of life. Just trust me, okay? And just as a random reminder, remember, if you do have high loop gain, some of the things that are available are oxygen therapy, CO2 therapy, the ERS device, stuff like I said, azolamide, ASV, but that's only for long cycle periodic breathing. If someone were to come to me and ask, what's the best thing that I can do to help improve my quality of life because I have sleep disorder breathing, and they're already trying PAP, this is what I would say: exercise and eating cleanly. Try to exercise every single day and stop putting junk into your body. Your body's already under a huge load and a lot of stress from this health complication that you're dealing with. So in any area that you can essentially prevent adding further load, you should. And those are the two areas that I think provide you with the greatest benefit. I know it sounds super cliche and so obvious. Like, what am I even subscribed to this guy for? He's telling me to exercise. I mean, obviously I need to exercise. That's what my GP says to me every time I go in there, and that I shouldn't smoke and blah, blah, blah. But it's still true. And I don't care about my subscribers. I don't care about my viewers. I just care about getting the truth to the people who want to hear the truth. And yeah, I'll stop there. But good luck, everyone. If you want to talk to me one-on-one, there's a link below. I hope everyone finds better sleep. I love all you guys. Thanks for watching. Blah, blah, blah.